Okay, the term antenatal means prenatal. It's just another way of saying it. We couldn't do it nicely. But when we're talking about antenatal assessment, we're talking about assessing what status this fetus is at prior to birth happening. And it includes things like maternal history, certain risk factors that's going to make this a problematic birth, some physical assessment that we end up doing, we'll talk about those, some monitoring during the delivery process, and we'll talk about high-risk conditions. We think of baby having problems being born, but that can also affect mom. So mom, just the process of birth, the process of parturition, can end up having mom having a lethal event happening. They're not common, but they're common enough that we need to worry about them. Some maternal histories and risk factors. First of all, anytime you have a preterm birth, that's probably one of the biggest causes of mortality and morbidity. You guys know the difference between those two terms, right? Morbidity and mortality. Morbidity means sickness. Mortality means death. We talk about both of them. Small percentage, but a significant percentage of births. And the smaller the infant, the bigger the risk. So if I have a 36-week, that's not as bad as having a 32-week or having a 25-week or something younger. The preterm birth is often the consequence of preterm labor, where we're going into labor before the bun is entirely cooked, if you will. The preterm rupture of membranes, where we'll talk about that uterus becomes detached from the placenta becomes detached from the uterus. And there's certain things as far as mom having distress or baby having a distress can end up triggering that preterm birth. Also, if mom has had a preterm birth, the chances of her having a second preterm goes up. So it's just kind of one of those things that if you keep having kids prematurely, the more kids you have, the bigger chance you end up having. Another cause or another risk factor has to do with the uterus not being in the proper position, or the cervix, as we'll talk about, being incompetent and not being able to provide for an easy delivery. Some other maternal factors, toxic habits in pregnancy, and more often than we like to talk about, smoking certainly is a huge risk factor. Carbon monoxide and nicotine decrease oxygen delivery because it decreases the amount of oxygen to be carried on the hemoglobin, even fetal hemoglobin. They typically are associated with a smaller birth weight than you would like to have, and they're also associated with premature membrane rupture and all kind of other problems. And then alcohol is teratogenic, and that's something called fetal alcohol syndrome. And there's certain characteristics that you end up seeing, but by far, alcohol is associated with some of the, as it says, most serious neurobehavioral effects in the fetus. And this is some of the things with fetal alcohol syndrome, some of the, I don't expect you to know these, but it's just kind of when I'm talking about it, well, how do I know this child has this problem? There's certain characteristics that end up developing in the child's face. Smooth philtrum, a little bump that's in between on your upper lip. So anyway, some other toxic habits, not only alcohol, but also looking at illicit drugs like cocaine, which can lead to reduction in flow through the placenta. Opiates, which are going to depress the respiratory system. So quite often, or not quite often, but if mom is a known opiate user, the chance of the baby coming out depressed is quite significant. And as we'll talk about when we talk about resuscitation, the use of a drug called naloxone or Narcan often is needed at that point. Poor nutrition, which can lead to the presence of maternal diabetes as well as the child developing diabetes. And one of the hugest risk factors is lack of prenatal care. There's been situations where somebody shows up to the ER 35 weeks pregnant and in hard labor and has never seen a doc. It's like that's just a recipe for disasters in the process. Some other risk factors: multiple births. Singlet, not a problem. Twins, a little more of a problem. Triplets, more of a problem. You can go on from there. Maternal infection, especially anything that's vaginal in nature, can lead to problems. Abnormalities of the placenta, we'll talk about. The placenta just isn't hooked up right, the placenta is in the wrong position, the cord is around the neck, all kind of things can end up happening. We'll talk about disorders of amniotic fluid, because that makes a big difference too. We'll talk about mode of delivery as far as where they're at, how the baby's positioned, are they in the right position? And toxemia as far as having, well, I think next slide, yeah. This is something that complicates, again, multiple deliveries, and other than pulmonary embolism, this is the biggest cause of maternal death associated. Two terms you need to be aware of: preeclampsia. Preeclampsia is a condition where mom is hypertensive, profoundly hypertensive in some cases. This is where we have a rise in blood pressure, 30 millimeters mercury systolic or 15 diastolic. It's associated with them spilling protein into the urine. If you remember from your anatomy and physiology class, the kidney normally does not filtrate or does not allow protein to get into the glomerulus, and it should not be there. When there's a high blood pressure, it pushes it across. And we see blood pressures get pretty significant. 160 over 110 is considered severe preeclampsia. If not treated, preeclampsia goes to eclampsia. Okay? So moms who are at high risk, that have high blood pressure, what do we do for them? Get off your feet, stay in bed, bed rest, the whole 9 yards. Because eclampsia is where we have convulsive seizures. And these seizures can be severe enough that you end up having comatose, you end up having death. So these are not something to play around with by any means. And they can occur even post-delivery. So even when you get a little rugrat out of you, you're still causing the problem. So preeclampsia and eclampsia, those are called toxemias. Diabetes can be either pregestational, meaning mom has diabetes going into this, and that's a bigger risk than, again, for that preeclampsia and eclampsia to develop. It can have, and by the way, mom can pass that along to the fetus. And then there's also what is known as gestational diabetes, where it occurs or is first recognized during the pregnancy. And this is associated with babies that are large for gestational age, meaning they're big kids. And because of that, vaginal delivery often is not a very nice process. Okay, so, and it's also a trigger a lot of times for preterm delivery. And that diabetes, again, can lead to the child having problems with various metabolic disturbances, including diabetes. Infectious diseases, the primary one you want to know is Group B Streptococcus. This is what is colonized in majority, or not majority, but some pregnant women. And we see this in the latter stages of the gestation. You can also have various herpes, viruses, and in some cases, if it's persistent, they may need to do a cesarean section as opposed to a vaginal delivery. And there's also hepatitis and HIV that are potential risks that are there. Caught it. So let's talk about the umbilical cord and the placenta. First of all, this is important because the cord can become compressed. Here you have a knot, here you have what are called knuckle cords, where they're actually just wrapped around the child's neck. They're floating around in there and they get all tangled up with the umbilical cord, and it ends up becoming bad. And there's our knotted cords. And here's when they talk about velamentous cord insertion, means the cord isn't really inserted well into the placenta. So you end up having basically an inability to adequately exchange nutrients, oxygen, carbon dioxide. in the process. A couple of terms you want to be aware of. Prolapse cords. Prolapse means that the umbilical cord is passing before the baby does. It's getting in the way. Here you can see the cords actually hanging down before the baby's even out. The baby should come first, then the cord. Okay. This can be occult in nature, where you don't see them, but the cords are actually there blocking the outlet. Either way, it's going to cause asphyxia. Okay. Asphyxia, as we'll find, is a bad thing. In addition, you can end up having the placenta not being placed properly. Normally, it's placed in the upper portion of the uterus. If the implantation occurs in the lower portion, we're going to call this placenta previa. Placenta previa. It could be either just a low implantation where it doesn't cover the cervical opening. It can be partially covering. We're going to call that a partial placenta previa, or we can have a total situation. So in other words, when the uterus is contracting during birth and the child's coming down the birth canal, if that placenta is sitting in the way, there's no way to get that kid out. It's not going to be able to pass in the normal fashion. So here's an example of a normal placement. You can see the upper third, or the upper third of the uterus is where the placenta is implanted. And here you can see it's a complete placenta previa. It's blocking the outlet so the child can't. And again, partial would be that there's some opening there, but it's not enough to adequately allow for vaginal delivery. Second type is abruptio placenta, or placenta abruptia, however you want to say it. And this is where the placenta becomes separated before it's time to. This usually triggers a labor, especially in the premature sense. Mortality is quite significant, both for mom and for baby. Mom simply because you bleed and she loses a lot of blood. Baby because they're not being oxygenated, become asphyxic. And it really depends upon how much blood is lost as far as where the mortality lies. Most common cause of abruptio placentae is preeclampsia. And again, that separation can be partial or complete. And you can still have a hemorrhage even though it's not seen. But most often you'll see vaginal bleeding. And this bleeding can be significant enough that you go into hypovolemic shock. Hypovolemia means that you don't have an adequate amount of circulating blood volume. Positioning. This is the normal position the baby should be lying prior to birth. It's called the vertex position. I don't know if I want somebody to draw something on my belly, but whatever. Any other position is not good. Breech is defined as having your foot, your leg, and your buttocks all coming out first before the head does. The head should be engaged in a normal delivery. You can have an incomplete breech, where it's maybe just a foot that's coming out first. That's got to be a weird looking thing. You can have what is called a frank breech, where the butt's coming out first. Transverse lie. The name implies, let me see if I got them here. Here's some examples of some of the breech: a complete breech, a footling breech, or a frank breech. You can have the head maybe coming first, but coming at a bad angle, so that the face is basically being scraped along the side of the cervix. And you can have the brow where that's not a proper positioning either. This is transverse lie. This is a bad one. The only way you're going to get that baby out is a C-section. Because babies aren't designed to come out in that direction. Just saying. And there's an example of gross way of doing the C-section. Indications for a C-section obviously is a breech or a transverse presentation. Prior C-sections usually will require a subsequent C-section. And when we identify the fetal distress happening and there's not time to have an adequate vaginal delivery, they'll go for a C-section also. It's not benign, obviously. You're just cutting into the abdomen and into the amniotic sac, and you can end up cutting the placenta, cutting the cord, or cutting the fetus, which is not often a good one. We're going to find there's a disease, and we'll talk more about it as we go along, called transient tachypnea of the newborn. That's what TTN says. Don't need to worry about it just yet, but basically because we're not doing a normal vaginal delivery, there's a tendency for not all the lung fluid to be pushed out. We'll talk more about that later. Whenever you have a hypoxia, hypercapnia, and acidosis together, this is, again, neonatal asphyxia. Basically, you're choking them off. It can lead to irreversible damage, specifically brain damage, and other vital organs. It can occur in utero. It can occur during the delivery process. The goal should always be to minimize or prevent that asphyxia. Why the child gets asphyxic is either perhaps mom's hypoxic, okay, or asphyxic. There's a reduction in placental blood flow, so baby's not getting adequate blood flow. This would be an example of the cord getting a kink in it or getting a knot in it. Anemia of the fetus, and certain drugs given to mom, or taken by mom for that matter, can lead to an asphyxic episode also. So let's talk about a little guy growing on the inside. How do I know where he's at as far as his development? There's multiple ways to end up doing these. I'll go through them. Ultrasounds are probably the most common way that we end up evaluating where mom is at. If there is some question, we can do something called an amniocentesis. There is what they call a fetal biophysical profile. It basically is how does the baby respond to stress. And then we'll talk about fetal heart rate monitoring and scalp blood. Ultrasound, again, ladies, if you have had an ultrasound, you can chime in anytime you want if I'm saying something weird. But basically, you're able to take a look at how the baby's developing on the inside. It can give us an idea of where the placenta is placed. So if I do have a low-placed placenta, I'm going into that delivery knowing I may have some problems. It can tell us the amount of amniotic fluid. And I think Mary covered that last time as far as polyhydramnios and oligohydramnios, yes? Both are bad. We want the right amount of cushion in there. And I can also assess the growth of the fetus inside mom. Amniocentesis, as the name implies, is where I go in and I collect some amniotic fluid. And it's usually guided by ultrasound. And you can do it as early as 15, but it's usually done towards the second or third trimester, and there are complications associated with it, as you would imagine. Lots of different things. Yes?
This might be a silly question, but for an amniocentesis, how do they get that fluid without rupturing the sac?
They're just puncturing it. It's a small enough needle that it's not going to cause a lot of leakage out of it. It's a complication, obviously, and that's what will lead to the infection involved. Yep?
What is the reason you haven't?
Well, say I see something that doesn't look like quite right in the baby's development. I have an ultrasound and I'm seeing something odd. They can go ahead, and this is the various stuff that they can end up finding. Not only LS ratio and your PG levels to determine lung maturity, but you can also look at things like alpha fetoprotein, which talks about skin rupture. That's where you may see something along the lines of that spina bifida, where you're having the skin not closure. You can also look at the RH status to see if there's incompatibility with mom. And we can also see if there's any fetal matter, what we call meconium, present. Usually it's used especially if I suspect there's some abnormality in the child's development, specifically, as I know, chromosomal abnormalities. There's a whole slew of things that can go wrong with the chromosomes. And this can lead to everything from a Down syndrome through trisomies, which are very odd, mixed up chromosomes that in many cases do not allow for a viable fetus. So, Nonstress test. This is where you basically, as the baby inside is moving, you should see the heart rate go up. And the heart rate usually is observed for about 30 minutes. And we just basically look to see if there's acceleration, speeding up of more than 15 beats. And the normal basically is that you want to end up having a couple of accelerations over that 20-minute window. So the baby should be moving around is the essence of it. And this is where we're looking at the fetal heart rate up on top. And you can see there's little bits of increases periodically as the baby's moving. That's what you want to see, just at rest. Now there also is a way that we can assess whether or not with a contraction are we seeing some changes. And this would be if I suspect that there's some problem with the uterus or the placenta being a good conduit. And as I end up having an interruption of maternal blood flow, those contractions can be happening. We can actually induce this by using a drug called oxytocin or pitocin. And we'll find that if mom is having a prolonged labor, it's one of the things we can end up doing is pushing it along, assuming their term, to go ahead and have that contraction starting. A positive test is basically if we have 50% of the contractions having a late fetal heart rate deceleration, and I'll talk about that in a sec. And a negative or a good test is what you want to see is that there's no decelerations happening. There is what when we talk about APGAR scoring in a few weeks, it's a scoring of post-delivery, how fit the child is. This is kind of a similar thing, but it's done prenatally. And it's looking at is the baby breathing? Is the baby moving? Do they have extension and flexion of their arms and legs? How's their heart rate looking? And then looking at the amniotic value or the amniotic fluid. And normal score is about 8 to 10. I don't expect you to memorize that. I'm just making mention of the fact that there's different ways that we can assess where baby's at in the delivery, which is one of many tools. And this kind of gives the description, this is out of your text, as far as what a normal score is and what an abnormal score is. And 8 to 10 is what you would expect to see. All right, this is something that you do need to pay attention to. It's called fetal heart rate monitoring. Normal fetal heart rates between 120 and 160, or roughly about 140. Kind of gets towards the lower end of that norm as we get closer and closer to term delivery. This can be a very good, but unfortunately not a very sensitive test of fetal distress. So if something's going wrong with that delivery, fetal heart rate can be used to tip us off that, ooh, we got a problem and maybe we need to look at doing an emergency C-section. And it has a correlation to contractions. Okay. We first talk about the fetal heart rate itself. Normally when you're less than 120, or you end up having a decrease by a greater by 20 or greater from the baseline, this is usually a bad thing in the sense that it's often associated with asphyxia. It can also be due to hypothermia and some drugs given to mom, but asphyxia is what I want you to focus on. Tachycardia, other end of the spectrum, is usually caused because of fever. Usually caused because mom's got an infection. Okay. Could be the baby has one also, but usually it's associated with maternal fevers. Decelerations. Decelerations are a natural process that occurs during delivery. During contractions, the fetal heart rate goes down. And this is where it can drop below 120 for a period of time, a couple of minutes or less. And there's 3 different types. And you should note that not only are there 3 different types called early, late, and variable, but they're associated with certain factors. Early decelerations usually coincide with uterine contraction. As the head is coming down, the vaginal canal starts to get squeezed by the contraction, heart rate decelerates. Okay, it goes on down. These are benign. These are normal decelerations that you end up seeing. Early decelerations. Late decelerations, where the contraction begins, and it's not until it's basically at the peak of contraction, or the contraction is almost over, that you end up seeing the deceleration happening. So it's not in sync at all. And this is usually associated with some insufficiency and fetal distress. So this is the bad one. Early are good, late are bad. Unfortunately, what we see most of the time is variable. It's not tied at all. It can have some problems as far as cord compression and fetal hypoxia, but it doesn't necessarily have to. So here's an early, if I'm looking at fetal heart rate on the top, and this is looking at contractions. So here's my contraction, here's my deceleration, timed perfectly with each other. That's what you want to see. Type 2, contraction, deceleration is happening well after it. Contraction, deceleration after it. That's a bad thing. Okay. Those are telling me something's wrong with the baby getting the proper amount of oxygen. In variable, there's no timing to them, and unfortunately this is what we see most of the time. So it means we have to sequentially monitor the fetal heart rate during contractions and making sure that they're in sync with each other. If not, it could be a sign of fetal distress, and it may necessitate getting the baby the hell out of there. Lastly, I want to talk just briefly about fetal scalp pH. So we're drawing blood from the baby before it's even born. We take a look at the vaginal opening and we see the baby's head beginning to crown, meaning beginning to show itself. At that point, we place mom in the lithotomy position, and ladies, I'm sure you know what that is. And we visualize the fetal head coming through the cervix. We remove a small amount of blood, and we can identify how acidic they are. And that's what you need to understand, is how acidic they are. Normally, it's about 7.25. When you get below 7.15, you got problems. Baby's in a real world of hurt. Ideally, you should look at what mom's pH is also, make sure she's not having all kind of problems, but typically that is not as much of an issue. It's a sign of asphyxia. I kind of like that picture. I don't know why, but I do. So let's talk about some other stuff associated, but first we need a video. Are we doing okay? Do we need a 2-minute break? Plug out. Let me skip through these. It's large amounts of fluid in the amniotic sac is polyhydramnios. 1 or more seizures, eclampsia. Which of the events is most important risk factor of the ones that are there? Preterm. What is the main problem associated with premature rupture? Yep. Should have been maternal hypotension. Didn't show up. Okay. Oh, I'm sorry. Fetal infection. Ah. You just noticed a little yellow on there. Okay. How do I know when I should expect a little surprise? It's called the estimated data confinement. I'm not sure why that term is used. That sounds just mean. Delivery date. No method is entirely accurate. There's 4 of them that we can end up using. Nagel's rule is the most common, and this is what I want you to know. So if I gave you an example, basically we subtract 3 months from the date of the last menstrual period, and then we add 7 days. So let's say the first day of the last menstrual period was March 25th. I go back 3 to find a December 25th, add 7 days, and it puts me at January 1st. So know that formula. Does that make sense? Go back 3 months, add 7 days. So if you really want to have fun, go back and figure out when your parents were. I think mine came out to be New Year's Eve, and I was like, oh God. The fundus of the uterus is the top of the uterus, and we can estimate how much growth has happened by looking at where the fundus is at. It's not really good for the last trimester, but basically if we take a measurement from the symphysis pubis to the top of the fundus, that distance is basically the number of weeks gestation the baby is at. Gross measurement, 20 centimeters, 20 weeks. You can use what is called quickening. Quickening is when mom first feels that movement. It's usually about 20 weeks. And again, it's a rough estimation. Quickening is the term. And we can look at fetal heart rate. Fetal heartbeats can be heard as early as 16, and by 20 we pretty much always have them. There's actually technology by using Doppler devices that we can actually hear them earlier, but as far as just direct auscultation. Something bad that can happen that gives us a clue as far as some distress usually is where there's a presence of meconium in the amniotic fluid. We know the meconium is the dark greenish stool found in the fetal intestine. And passage of amniotic fluid often occurs in postterm babies, but it can also occur during if the baby becomes asphyxic. Okay, they basically poop their pants, if you want to think of it that way. And in the process, what you end up having is meconium in the fluid, and the potential for the baby to inhale that, and it becomes an obstructive element. And it's something called meconium aspiration syndrome. We'll talk more about it when we get to pathologies associated with it. Talking about maternal history. A couple of terms that we want to be able to have down. Gravida is the first one. Gravida is the number of pregnancies regardless of duration, regardless of outcome. So it includes both therapeutic and spontaneous abortions. And we use the term prima gravida for a first pregnancy, multi for more than one. Term. If you notice, there's these letters here, G, T, P. That's kind of important. T means how many? You don't have this? Okay, I'll get it to you. I'll email it to you today. T is term. How many babies had a term birth or at least 37 plus weeks? Okay. P stands for preterm. How many of them didn't get that long? A stands for abortions, either spontaneous or induced. L means the number of children that are currently living. It's okay, guys, I'll send this to you. And P stands for para. And I do have it on Panopto. These are the number of pregnancies. Notice the term, pregnancies, not babies. Pregnancies that reach 20 weeks gestations. It's basically an index of how many times the uterus has been stretched. Okay? Not the number of children. It includes live births and stillbirths. Okay, that's para. So we can basically describe a woman who was pregnant once with twins at 35 weeks, and both of them survived. Her next pregnancy, then, we would say she's G2, 2 gravidas, 0 T, T again stood for term. Neither of them went 37 weeks, they only went 35. Second P is preterm, so we had 2 preterm. Obviously, if they're not T, they got to be P. A, abortion, 0. L, number of living children, 2. So that's a way we can describe what mom's status is. Because if she had preterms previously, there's a good chance this is going to be preterm. Good enough. And it's also just as a G and a P, it's G2P1, 2 pregnancies, one of which reached 20 weeks. The current one we're not counting. All right, this process of parturition, the process of giving birth, has 5 events that we'll think about. Rupture of the membranes, meaning that the plug which is holding fluid in the amniotic sac comes out. The water breaks. The cervix dilates, and I'll show you a picture of that. The uterine begins contractions, the placenta separates, and the uterus goes back to its normal size. Labor, we can say, has 3 stages, where stage 1 has 3 phases: early, active, and transition. And this is where the contractions become regular, and we end up having what is called full dilation and full effacement of the cervix. We'll again get back to that description in a second. Stage 2 is the actual functional delivery. Stage 3 is the delivery of the placenta, and then there's a recovery stage that is there where basically, again, the uterus shrinks back down and we're back to normal, quote unquote. False labor, known as Braxton Hicks. Braxton Hicks contractions are contractions that feel like they're real, but they're benign. Pardon me? I'll take your word for it. But they are fairly mild compared to true contractions. So stage 1, we end up having effacement and dilation. This is where the cervix, the opening through which the baby has to come, stretches and thins. That's called effacement. So the cervical wall actually thins itself out, making the vaginal opening, or making the delivery opening bigger. The cervix then also widens, and that's called dilation. Effacement is measured as a percentage, with 100% meaning the cervix is imperceptible from the uterine wall, we're fully effaced. And dilation is measured in centimeters, with 10 centimeters being the maximum. So when we're going through this first stage of labor, the measurement can be made, and we'll say the mom's at 2 centimeters and 40% effaced, meaning we got a ways to go. So good so far? Stage 2, again, delivery of the fetus. This is where the uterus, which is a very muscular organ, facilitates the descent of the fetus by the contraction. And again, we want the head down, vertex position, and as the baby's coming out, the head actually turns back over. So they're coming down face down, and then they rotate themselves around so that they come out face up. Then the umbilical cord is clamped once the baby is out, and all the magic happens. And then at some point in time after baby is out, the placenta separates itself from the uterine wall and is basically delivered out also. It should be a benign process, but there's always the potential for that tearing to occur and for bleeding to happen at that point. This process of delivering the placenta can actually be sped up by having baby now born join mom in breastfeeding, and that releases a hormone called oxytocin, which basically increases the contraction and pushes the placenta out. All right, this is a great little video. You can see the effacement, you can see the dilation. Baby is coming out face down. The head has to change its shape. That's why the bones aren't solid in your skull. Coming out through, hello world. It flips itself around. Sometimes you need assistance to be able to do that. Shoulders are the hardest part to get out, and they can cause a lot of damage. And then once that point comes out, we're on out of there. Great little video. All right, preterm. Again, this is where we're starting this whole process before we want to. We're only at 26 weeks. We don't want to have labor starting. So this is a bad thing. And again, high risk, all those things that made it risky for mom to be delivering a child makes the chances of preterm labor happening more so. Preterm delivery then is what often will follow unless we can suppress that labor from happening. And there's multiple things that you can end up seeing. We talked about risk factors for preterm delivery, previous ones happening, rupture of the membranes, infections, multiple gestations, placental issues, cervical insufficiency. So basically, we start seeing 6 contractions in 1 hour. That's considered to be labor. If it's not quite term time yet, that's considered then preterm. The goal that we want to be able to do is something called tocolysis. And tocolysis is basically stopping labor. Making sure mom is well hydrated is the first step, and then we use certain adrenergic drugs, beta sympathomimetics, gee, those sound awful darn familiar, to relax the uterine wall. The uterus and the bronchial smooth muscle have very similar characteristics. And terbutaline, which we saw as being one of those bronchodilators, is also used as a mechanism to stop labor, as well as magnesium. And there is a substance, indomethacin, that can be used also. So it's a prostaglandin inhibitor. What I want you to know is terbutaline. That's important. When would I want to do this? Well, when the baby's not 38 weeks gestation. We'll do it somewhere between 20 and 37. And it's where you're actually seeing that true labor happening. And in this case, typically, because we're premature or not quite ready, we don't have the centimeter qualification or the effacement qualification. If the cervix is dilated more than 2, well, it's time to come. How much you can do with it at that point. You have to have intact amniotic membranes. It has to have no fetal distress. So we want to suppress those contractions from happening. When we wouldn't do it are some of the either absolute or the relative. I just give you these. I'm not going to give you a multiple choice. Which of the following is not? Which would be mean. Another term, dystocia. Dystocia refers to difficult labor. This is where the first and second stage is lasting an awful long time. Stage 2 being more than 2 hours. This is the delivery. Stage 2 being more than 2 hours in a first time, or 1 hour in a mom who's had a previous vaginal delivery. As length of labor increases, we get more and more problems. And more problems are from either the placenta prematurely separating, the cord being compressed in some fashion, or there being an increased risk of infection because of premature rupture. Why do we have dystocia? Well, maybe the uterus just not functioning like it's supposed to. Maybe it's because of fetal presentation. Maybe it's because baby's a little bit too big for mom to handle. Could be hydrocephalus, where the head is abnormally enlarged, or it can be where the birth canal isn't developed in the proper shape and size. You'll see this a lot with moms who are delivering who are very young in age. A 14-year-old. She's not going to have as well of a developed of a birth canal, and any size baby is going to be large for her. So dystocia is quite common. Multiple gestations. Sounds like a good thing. We're kind of not necessarily designed to have multiple kids at once. Twins, roughly 1 in 100 births. It's kind of interesting that it's less common in the Chinese and more common in African American. Not sure why. Other groups are a little bit more rare. I got data there from 2010. 5,000 triplets, 3,000 quads, 37 quints or more. And an example, I always point to this one because I was actually working in sales at this time, and I had Grand Rapids as my territory. But the Van Houten sextuplets, there was 6 kids born on 3 different days. Huh? Obviously, we had multiple amniotic sacs. One ruptured on January 7th, delivered that kid. The other one ruptured on January 16th, and between the 16th and the 17th, delivered the other children. Somewhere between 23 and 25 weeks gestation. Total poundage was 9 pounds 2 ounces. That's a good sized kid by itself, but these kids were awful small. Yeah.
Are they sharing all one placenta?
No, they couldn't if they were delivered on different days. They were born at DeVos Children's Hospital in Grand Rapids, and unfortunately, some of them did have some birth defects associated with the prematurity. Got that? You're always going to run that risk. But to my knowledge, all 6 of them are still alive. So, obviously, multiple gestations are a bigger risk to mom, bigger incidence of premature labor, premature delivery. What I want you to know is twin B is always worse than twin A. They are more prone to developing respiratory distress because they're stuck inside a little bit longer. And if you had triplets, the C would be worse than B or A. So actually, the sooner you can get out of it, the better off you are. And for whatever reason, boys are always worse than girls. If there's twins, twin boy is going to be worse than twin girl. They have more. That's right. For whatever reason, the boys are more prone to having respiratory distress. Postterm pregnancy, assuming that it's not an inaccuracy in calculating our expected data confinement, because of the size of the child, you may end up having it be too big to deliver naturally or vaginally, so we have to do a cesarean section. Also, is that increased risk of meconium aspiration, because that fetal gut wants to empty it out, and we end up having perhaps problems with inadequate nutrition because of placental insufficiency. Just can't keep up with the size of the kid. And again, oxytocin, we talked about something to stimulate labor contractions, can be utilized to speed that process along. So let's go back through this adaptation to extrauterine life. Baby's out, now what happens? Fetal breathing actually occurs quite early in gestation, possibly as early as week 18. It's definitely there within the last 10 weeks as far as their diaphragm contracting and their attempts to take breaths, training basically the diaphragm in the process. Initiation of that first breath can be caused to asphyxia. We know high CO2s, low PO2s, low pHs. They can stimulate a gasp. Usually the first breath, though, is taken because of recoil of the thorax. As the thorax is coming down, it's being squeezed. Once it's outside, it opens itself up and the baby's breath occurs. Think about what's going on. I'm in this nice, warm, moist, dark environment, and I come out into this ugly, cold, bright lights. What the hell did I just do? Right? Get me back in there. And also the tactile stimulation of them being dried off will allow for it. Quick little joke. I got a few minutes. Little woman's out. She's due to deliver. She lives out in the country. She can't get to the hospital, so the doc comes there and he says, it's at night, and says, well, I need somebody to hold the flashlight. And he said, there's nobody here but my 5-year-old son. I said, well, it's time he's got to learn the facts of life here. So he's holding the flashlight, and his eyes are getting bigger and bigger and bigger. And the baby comes out, and the doctor smacks the little baby to start crying and goes, yeah, hit him again. He had no business crawling in there in the first place. Huge amount of negative pressure needed to generate that first breath. They estimate somewhere about 100 centimeters of water. You need to basically fill those lungs for the very first time. Okay. As subsequent breaths occur, because I've established that FRC, less and less is required. And we know that as the alveoli collapses back down, surfactant being present prevents premature collapse of that alveolus. So the bottom line is that each breath, because I'm establishing that FRC, requires less and less breath because the compliance is improving. And this is just kind of showing the very first breath needing a whole lot of distending pressure, and then as you keep going, eventually we're right here in the red. Not a whole lot, but that first breath is going to require a whole lot of pressure distension to get the open and establish a volume there. Not only do we have the first breath doing something, we also had the clamping of the umbilical cord. This is what I was talking about that Mary might have covered last time. Cord is clamped. Now there's no more blood flow going to the placenta. So now what was the low pressure system being the systemic circulation in utero, now once that is closed, the systemic circulation becomes the high circuit system. Okay. If you think about it in utero, the pulmonary vasculature is clamped down because we don't need blood flow going to the lungs because there's no gas exchange units there. Well, there's units there, but they're filled with fetal lung fluid. Once that cord is clamped, then you end up having now the systemic vascular resistance rising. Okay? Yeah.
What did they do before modern times when they didn't clamp?
Got me.
Yeah.
Well, you would have to do something to cut the cord at some point.
Some other instinct or something.
I have no idea. I watched some of these births where you see, there was one I had of a giraffe being born, which is, wow, weird.
Yeah. I've done calves, split 20 of calves, and I won't clamp nothing.
Clamp it off.
Oh no. Mother does the rest.
That's right. Mother knows somehow or other. But again, that high vascular pressure on the left side, on the systemic side, now causes the left side of the heart to be a greater pressure than on the right side of the heart. This is what causes the foramen valve to close. Clamping of the cord, increase in SVR, that left side of the heart becomes a higher pressure circuit than the right side, foramen valve close. Very important concept. As the baby takes that first breath in, its lungs are now filled with oxygen. Remember, a decrease in oxygen level is a huge pulmonary vascular constrictor. What causes a high pulmonary artery pressure, a high pulmonary vascular resistance, is a low PO2. So as I'm getting this fresh oxygen in, it causes the pulmonary vasculature to become the low pressure circuitry. So pulmonary artery pressure falls, right side of the heart pressure falls, and we end up having left atrial pressure exceeding right atrial pressure. And this causes that shift in perfusion through the foramen valve. And then during the last few weeks of gestation, we start seeing some smooth muscle developing around the Ductus Arteriosus. Again, this is the third ductus venosus connecting the liver with the systemic circulation, or with the venous circulation. forming a valve between the two atria, and ductus arteriosus between the pulmonary artery and the aorta. The ductus is stayed open because of prostaglandins that are being released in utero. When you have a high PaO2, the prostaglandins aren't secreted. So the combination of the first breath rising the PO2, lowering the PVR, and the high PO2 then causing prostaglandins to be inhibited, this keeps the ductus arteriosus open. Okay. I'm sorry, causes the closure of the ductus arteriosus. Let's rephrase that. First breath, high PO2, in conjunction with PO2 inhibiting prostaglandins, which were pushing it open. If for some reason the PO2 does not stay high, the potential exists for that ductus arteriosus to pop back open again. We're going to call that a patent ductus arteriosus. And we will see with a lot of disease, let me rephrase that, a lot of pathologies in the neonatal world, these babies are hypoxemic. And because they're hypoxemic, their PDA stays open. What does that mean? That means I have blood that's from the pulmonary artery, venous blood, right? Reduced PO2 blood, pumping itself into the aorta. A big shunt. Okay. And where the ductus arteriosus is located is usually after the after the brachiocephalic artery branches off the aorta. This is why we end up having a difference in a right-sided pulse oximeter versus a left foot pulse oximeter. It gives us an indication that we have a PDA. Very important concept, as we will find as we go through this. First breath causes the ductus arteriosus to close. Clamping of the cord causes the foramen valve to close. Ductus venosus and umbilical vein, these are basically when the cord is clamped, there's no more blood flow through them. They constrict and just basically become ligaments inside you. This is kind of a nice picture that's out of, I believe out of Beachy, showing the different oxygen contents in various areas of the bloodstream. Yeah, I think that's it. Okay? Don't go. I have a present.
Bring it one.
Same as last year?
full contractions every day, and you're counting on it. They don't release blood more. Is that even possible? Really? So you can almost get all the way up to right about
They can go ahead and they can manually.
Really?
I was just like, I got
Sometimes they make this blood make it hung up.
Really? Yeah, I was blown up years ago.
And a lot of times they can have their water break and not even realize it.
Really?
If it's a small enough girl.
Yeah, makes sense.
I don't care. Rick, when do we? I know.
I didn't hear any.